Welcome to our second podcast on the cardiovascular system. In this particular portion, we are going to take our two-chambered heart with a single atrium, single ventricle, and we're going to partition this two-chambered heart into a four-chambered organ, and we're also going to partition the outflow tract into our great vessels, that being the pulmonary trunk and the aortic trunk. So we're going to begin looking at atrial septation. Now, at the end of the fourth week, this is by the time we are going to have our two atrial chambers. We start in that third week with a single atrium, and we are going to use two curtain-like partitions, two septa, that are going to form and basically drop like curtains. They're not going to be absolutely vertical and perpendicular, but they're going to drop at two different directions. Now, the important part of what's going to happen here is we're going to maintain a continuity between the right atrium and the left atrium at all times as we're forming these partitions. We're going to have a series of openings, which are going to be called foramen. And again, our two partitions that we're going to have are going to be the septum primum, and then the next will be the septum secundum. So follow as we move through. So the first septum, the septum primum, this is going to drop down. As it does, it's going to leave a crescent-shaped hole adjacent to our endocardial cushions, and this hole is going to be the foramen primum, or some refer to the actual hole as the ostium primum, and this is going to allow the blood again to mix from the right to the left side. So here we're looking both in a sagittal view as well as a coronal view. You can see our curtain dropping, and again, it's not coming straight down towards our endocardial cushions. They have yet to fuse. But as it comes down, there you can see our crescent-shaped opening. And this is going to allow the blood to move from the right to the left side as we're forming this partition. Now, as we get to the point of closing this partition, this is eventually going to fuse and close off the foramen primum. But you can see that we're already beginning to form perforations, and this is due to apoptosis, in this upper portion of our septum primum, and this is going to be the foramen secundum. Now, you're going to have a lot of primums, a lot of secundums, septums, foramens. You're going to have to keep these straight. So there you can see the beginnings of the foramen secundum. Here a little bit later, we're further closing off this foramen primum. By this point, we've completely closed it off. And now a lot of those little holes have coalesced into one opening now, and that's going to be our foramen secundum. So as the foramen primum closes, we now have another passage that allows blood to move from the right to the left side. Now it's at this point that we begin to see a second partition. Here's another crescent-shaped curvature that we see in a wall, and this septum is going to drop down, and this is dropping down on the right atrial side. It's not in the same place as the septum primum, and this is going to be the septum secundum that is going to begin to form. So we formed that hole that, again, allows the continuity from right to left, and here comes the septum secundum. This is going to be forming during the 5th and 6th weeks of development. And the septum secundum, like we saw with the septum primum, is going to grow downward, but this is growing down toward the inferior vena cava, actually. And as this is growing downward, it is never going to close its crescent-shaped hole. And actually, it's going to leave this oval-shaped opening that's present in this incomplete septum secundum. And since it's an oval shape, this is referred to as the foramen ovale. So here, in looking at this illustration, we can see this oval-shaped opening, the foramen ovale. As it's moving downward, again, it's getting smaller and smaller. And initially, we see the overlap. We can still imagine how blood can pass from the right to the left, even in this image. A little bit later, we can see that now the septum secundum has overridden the opening of our foramen secundum. But because of the position and the higher pressure of blood in the right side, this is going to be able to push between these two partitions. And because this is not a very substantial opening, this is going to act like a unidirectional valve. It's going to allow blood to move from the right side, push against this remaining portion of our septum primum, and enter into the left side. But the reverse is not going to happen at this point. primarily, again, because the higher pressure on the right-hand side. So because of that, at this point, the cranial portion of that septum primum, it's going to begin to degenerate, but that lower portion, that caudal portion, that's going to remain. And as we saw in the illustration, that's going to create a unidirectional valve. Now, we'll talk about after delivery how we change pressures once we tie off the umbilical cord, once we start having a pulmonary flow. Then the pressure is going to be greater on the left side, and that's actually going to push against this valve of the foramen ovale, and that's going to close off that foramen, and blood will not be able to move from left to right after birth, and will actually fuse. Here you see just a schematic of how this is going to work. Before birth, higher pressure on the right. It's able to move that valve of the foramen ovale, and we're using that in place of this portion of the septum primum. There we have our foramen ovale moving through what was formerly our foramen secundum. Now this is just a big open hole. But after birth, because of, again, of our pulmonary circulation, the higher pressure on the left-hand side pushes this portion, this valve of the foramen ovale, portion of the septum primum, against our septum secundum. That is going to fuse, and what we're going to be left with is a slight depression, and that's going to be called the fossa ovalis. Now, let's put this all together in animation, and maybe that will help tie all these different components together of atrial septation. Partitioning of the ventricle is much less complicated than what we saw in the atrium, and in fact, we're going to see a large trabeculae that's down in the floor of the ventricle, and this large crescent-shaped wall, and again, it's just like a big trabecular muscle. This is going to grow upward with the endocardial cushions toward that midpoint. But as it grows, we're going to see that there, again, is a small crescent-shaped opening that's going to allow the communication between the right and left ventricular chambers. And this opening is called the interventricular foramen. Here in both of our views, we can see this large interventricular septum. And again, it's going to start in the floor of the ventricle, and it's going to grow upward toward our fused endocardial cushions. And again, it looks just like a finger in this point. But if you could look at it in this sagittal view, you can see it is a wall, and there is our crescent-shaped interventricular septum, interventricular foramen. Now, this foramen is not going to close because of the muscular aspect. The closure of the interventricular foramen is going to happen around the 7th week, and it's going to be largely due to contributions from our endocardial cushions, but also two other tissues. These are going to partitioning tissues that are septating the outflow tract. We call them the right and left bulbar ridges. And we'll talk a lot more about that when we get to that particular section and after we cover outflow tract, because it's not really going to make sense at this point. But all three of these contributions are going to form the non-muscular portion of the interventricular septum, which we simply refer to as the membranous interventricular septum. Now, again, let's animate this, and so we can see what's going on with the formation of the interventricular septum. I wish I could take a snapshot of the end of that image, but if you notice, and even if you go back in that mid-sagittal view, notice where that interventricular septum is moving up and how the outflow tract, which is on the right, I think you can imagine as we begin to septate that outflow tract, portions of that toward the base, that's where we're going to have that contribution. If you can kind of get that visually, it's really going to help you understand how this is going to close off and form the membranous interventricular septum. Bit of a review here. We know that in the ventricle we have this trabecular muscle, trabeculae carinae, and some of those muscles are expanded into our papillary muscles that are connected to the cusps of our valves by our chordae tendineae. And on the right side we have the tricuspid valve. The left side we have the bicuspid valve. But essentially the way these are going to form through development, because all we really have is our fused endocardial cushions. We have the lateral boundaries of our atrioventricular canals. We have our trabecular muscle. But we're going to begin to form some swellings that are going to occur in the valves. And we can see that this is going to happen. But we're also going to have erosion of some of our tissue, some of this trabecular tissue. And so as some of this tissue erodes, the cardiac muscle itself is going to undergo changes. It's going to degenerate and just become fibrous tissue. And so these modified cardiac muscle cells are going to become our chordae tendineae. So I think you can envision this tissue in these lateral atrioventricular regions, and even on the medial side of our fused endocardial cushions, we're going to be eroding this tissue, maintaining connection with our papillary muscles, and some of that intervening muscle is going to degenerate into fibrous cords that we know as the chordae tendineae. Once again, here's an animation putting the formation of valves and the erosion of this tissue into motion. So now returning to a little of complexity, the AV region, that was pretty complex. Forming the atrial septum, the ventricles weren't that bad. Now the outflow tract is going to be a little bit more complicated. We're going to have two ridges that are going to grow along the length of our outflow tract, that being within the bulbus cordis and the truncus arteriosus. And I want you to think of these as being analogous to our endocardial cushions. We're still going to have the cardiac jelly. We're going to have this acellular space separating the muscle from the endocardium. But we're going to see that rather than a huge contribution of epithelial-mesenchymal transition, we're going to have a huge contribution of neural crest cells that are moving in to populate these bulbar ridges. And again, we'll have the right and the left bulbar ridge. So we're going to look at our neural crest cells, and recall these are coming from the dorsal aspect of our neural tube, and then this cranial, cervical region rather, we're going to see these neural crests that are going to migrate downward toward this outflow tract region of the heart. There you can see this illustration. And they're going to populate this truncus arteriosus, bulbus cordis. Here you can see the right and left bulbar ridges, and there come the neural crest cells migrating in. And these are going to be our onlogin for the connective tissue in the outflow tract. As we form these ridges, the unique thing that's going to happen, they do not form parallel to each other. They do not form in a straight plane, much like we might think is a sagittal or a coronal plane. But they're actually going to spiral through the outflow tract, and they're going to create a spiral septum. And this septum is referred to as the aorticopulmonary septum. The name really implies the mechanism by which this is happening, and the fact that we are converting the outflow tract into and separating one another from the pulmonary trunk and the aorta. So as we look at these different sections, we can see that we have the bulbus cordis at the base, the truncus arteriosus, there we have our aortic arches. And at different levels, if you take a section and look, you can see both of those bulbar, some refer to them as truncal ridges, bulbar when they're in the bulbus cordis, truncal ridge, when they're in a truncus arteriosus. I just like to refer to them as the spiraling septum. But at level 1, you can see their position. Level 2, we've rotated 90 degrees. Level 3, we've rotated another 90 degrees. And if you could open up the outflow tract and look, you would see that spiral staircase look to those ridges. Now, that might not seem like a big deal, but once we fuse these, and over time, as we separate them, here you can see a nice illustration of the blood flow around that spiral septum. What I want you to appreciate is the exit point of the heart for our pulmonary trunk and for our aorta. This is on the right side, this is on the left side. And if you look at the pattern of the outflow, you can see that twisting, you can see that spiraling of these vessels. Now, I think you can imagine if that did not happen, then I think you can appreciate the fact that, yes, in fact, you would have the aorta coming straight down into the right side, the pulmonary trunk coming straight down into the left side. Now you've effectively transposed the vessels, and you have two closed circulations, one a systemic circulation and one a pulmonary circulation. This is called transposition of the great vessels, and it is in fact not compatible with life. You have to have a lot of these bypasses that we'll talk about when we talk about fetal circulation. They have to remain open until surgically you can flip those vessels back. So now let's watch a video showing the septation of the outflow tract. As we said with the ventricular septation, we are finishing that off with contributions from these bulbar ridges. And from our interesting view, here is our interventricular foramen. This is where we're going to form this membranous part. So as our bulbar ridges are starting to come down, and hopefully you noticed in that last animation the yellow and the blue, and how they were approaching that still open point there, just above our fused endocardial cushion tissues. Both of those are going to contribute. In this illustration, we can see that we've got our endocardial cushion tissue, and I hate that they switched the colors on us, but endocardial cushion tissue, we've got our bulbar ridges coming down, and both of those are going to grow down and contribute with our endocardial cushion to close off and form the membranous part of our interventricular septum. Once again, recalling from our animation, the yellow and the blue, and remember, this doesn't correlate with what we saw in the two-dimensional pics, but there you see the finishing of our bulbar ridges growing down, the endocardial cushions projecting up to close off that interventricular foramen. As we partition off the outflow tract and we look at what are the adult derivatives of these tissue, we're going to see the bulbus cordis become something that's called the conus arteriosus. Now, this is in the right ventricle, and this is the sort of origin or the orifice with which the pulmonary artery blood enters the pulmonary artery. We're also going to see on the left side, the aortic vestibule is going to form from portions of the bulbus cordis. And again, this is going to be an area that is somewhat inferior to one of the aortic cusps, and the orifice of the aortic trunk is going to slide under one of these cusps, and the blood is then going to flow in. So this sort of covered area is referred to as the aortic vestibule. Both of these are derived from portions of the bulbus cordis. We've talked about valves in the AV region. We've septated everything that there is in the heart. But now we need to talk about the semilunar valves. Now, these are going to be swellings on the pulmonary artery and the aorta in these orifices that prevent the blood from flowing back into the ventricles. So these are unidirectional valves. Now, for physiology, you probably remember that these are three cusps. They're referred to initially, and we'll see them on the walls of our pulmonary trunk and the aorta, as subendocardial swellings, a little bit like we see with Cushing's, but I almost hate to think of them that way because we're not going to see the epithelium mesenchymal transition. There's a whole different mechanism going on. But the blood flow, as the blood tries to drop back down into the ventricles during diastole, we're going to see that mechanical force helps to hollow out and reshape these into these cup-like cusps that are on the wall of our aorta and our pulmonary trunk. So here we can see our bulbar ridges. These are going to be in the outflow side. That's dividing everything up. And here we're going to have our cusp swellings, the swellings for our semilunar valves. We see these lateral ones, well, dorsal and ventral. Then we have these ridges. And once our bulbar ridges fuse, we are going to continue to form two more of these cusp-like swellings on either side. Here's our posterior lateral with the right and the left, with the right and the left. And if we're looking at these sort of from the top, but if we look at these in a sagittal view, here you can see the swelling. And because, again, of the mechanical pressure of blood dropping, these are going to hollow out and form these cup-like or pocket-like cusps on the wall. And with three of them, as during diastole, when the blood tries to fall down back into the ventricle, the blood is then going to fill these cusps, and that will completely close off these vessels and will allow simply the unidirectional flow of blood up, but never back into the ventricle. As we continue to remodel our developing heart, we're going to see that the sinus venosus, and again, this is more of a catch basin of blood returning back from the body, the cardinal veins, the vena cava, before we dump into our single atrium. And as we begin to remodel the atria, we're going to see that the sinus venosus becomes incorporated into the wall of the right atrium. From physiology, remember, the sinus venosus was where we had our pacemaker activity. And so that's why we refer to, in the right atrium, the pacemaker as the sinoatrial node, because it is derived from our embryonic sinus venosus. Well, in addition to the pacemaker, that sinus venosus tissue is going to look smooth on the inside of the right atrium, so we refer to that as the sinus venarium. The remainder of our atrial muscle is going to be called pectinate muscle. Now, if we look on the inside, we can see the sulcus terminalis, and this is going to be, on the exterior portion, this is going to be a groove that marks the junction between the rough, the pectinate muscle, and the smooth, the sinus venarium, that we occur in that right atrial muscle. Now, we're also going to see internally that there is a ridge, and this is the internal landmark then between the smooth and the rough, and this is called the crista terminalis. And we're going to see that there is a little bit of a contribution of this as far as aiding in the direction of the blood flowing from the inferior vena cava, which is largely coming back from the placenta toward the foramen ovale. Here we can see in our illustration this lighter color, that's the sinus venarium. The sulcus terminalis will be on the outside. Here on the inside we see our smooth sinus venarium, the rough pectinate muscle, And then we got the crista terminalis, which is going to be this dividing line. Here you see blood coming in from the inferior vena cava, and we're passing through the foramen ovale. Now, on the left side, we're also going to have a smooth portion, but this is not coming from the sinus venosus. This is actually coming from tissue that was formerly a pulmonary vein. Now, early on in your developmental growth, basically you had a single pulmonary vein entering in. It was almost like a pulmonary trunk, and we can see that illustrated in A. But as our atria grew, it began to incorporate more and more. It's almost like it expanded and it just consumed these lower portions of our pulmonary trunk, to the point that we get to this first branching, and in which case we have incorporated that pulmonary vein tissue into the smooth portion, and we now have two openings. And we continue to expand and incorporate more and more until we get to the next level of branching. And this is the final adult structure. We have the four openings of our four pulmonary veins, and we have this large smooth portion in our left atrium. So the smooth portions do exist on the right and left, but they are derived from different embryonic tissues.